Oh, and I hope you're having a good day there.
We are. It's very nice. Very nice. The weather is nice, and the day as a whole is very nice.
That sounds great. And with us here in Studio Envision are Kevin, who you just heard a little while ago, and also Lauren Zimmerman, who is a nutrition intern, is with us today.
Hi there.
Hello.
And since nobody else has gotten on, I think we'll go ahead, Hernan, and as usual, please let me know if there's anything that you want to discuss or you have any questions about.
All righty. Yeah, I'll let you know as we're going.
And also, Hernan, do you have a case today?
No, unfortunately, you remember I had promised you that case, but I couldn't convince the doctor to divert any of his time to trying to put that together. So, and I don't have any patients of my own.
Well, I appreciate your efforts, and I'm looking forward to there being a case for us to explore further sometime. As TPICC is depicted here as a microphone, but I don't always want to be talking into it. In the sense that I certainly want it to be more of a discussion, and I look forward to it being that way, especially with regard to case conferencing. Nevertheless, welcome. Definitely glad to have you here. Obviously, you know how to connect with us, and you are eligible to be receiving a CME for attending today's conference. Before I embark on our topic, my apologies for running a few minutes behind as I am challenged to make it from the school-based health center in back of the middle school up the canyon into Harris to this chair. Today we're going to be talking about prescribing medications to youth for depression and anxiety, and I'm going to work off of a PowerPoint that I've prepared for giving this presentation to school-based health center providers. Thinking today we would be covering the requirements and guidelines as they did this fall. And looking at how medication has really become a mainstay of behavioral health treatment, while, however, youth who are prescribed psychotropic medication and others involved, such as parents and other caregivers, often worry about safety of medication, question its efficacy, and really receive insufficient information from prescribers. Youth and others involved need more, that is, more sufficient and useful information before psychotropic medication is prescribed. And psychotropic medication really is part of an overall therapeutic process, and providing that information really fits in with a therapeutic process. Eventually, and I think it will be in the next installment, we can discuss more clinical psychopharmacology and take a look at the different psychotropic medication classes that have therapeutic uses for pediatric depression and anxiety, as well as some others that have been prescribed to youth who have depression and anxiety with much less efficacy and sometimes unfortunate outcomes. Well, the bad news, according to the psychiatrist whose back is before us, the son of this couple has behavior problems that stem from too little time, attention, discipline, and affection from his parents. The good news is we have a pill for that, which really I have to thank my father for sending that to me years ago. But he did so with full understanding of how medication and molecules are not the mainstay of psychiatric care and behavioral health care for youth. We really need to emphasize when prescribing medication that it is a therapy. And how do we use medications in a therapeutic way? Such as I alluded to earlier when talking about how sufficient information needs to be imparted, and that can be done in a therapeutic way. So that we want to make it psychopharmacotherapy versus merely psychopharmacology, which is emphasizing the properties and actions of the medications, which are real and helpful, but certainly not all part of what treatment is. We really want to emphasize the principles of effective treatment and look at the approaches for providing that treatment. So does this seem like a reasonable goal to everybody, that we want to have safe and effective psychopharmacotherapy for the treatment of pediatric depression, anxiety, and comorbidity, the related conditions? Seem reasonable enough?
Absolutely.
Yes.
Okay. Hence, we have number 1 as our main objective to list 3 requirements and 5 guidelines regarding safe and effective psychotropic medication prescription for youth who have depression and anxiety. And in the next installment, we can look again at those medication classes, and if we find it useful, we can talk more about how integration of the medication into a therapeutic approach is something that we can accomplish in the pediatric clinic like we do in school-based health centers. But for today, again, let's emphasize the listing of our requirements and guidelines. In doing so, our perspective is biopsychosocial, that we've talked about here before, is our main orientation. Well, I found it interesting and inspiring for this presentation to encounter an article in the New Yorker, actually handed on to me by a colleague, entitled "Head Case, Can Psychiatry Be a Science?" Clever title. Head Case. Appeared in the New Yorker, 3 years ago now, by author Louis Menard, or Menand, who claimed that psychotropic medications, especially antidepressants, are prescribed merely for normal responses to the human condition, life reactions to life that result in sadness. And that's really different than our clinical aim, which is really to treat known diagnostic entities, that we know that we have a clinical condition, that it's been found to be a disorder, and that our clinical assessment actually informs our treatment plan, rather than willy-nilly prescribing to help people deal with the normal stresses and reactions to life events. Because it is our comprehensive assessment that does inform our treatment plan. And as Wayne Hugo Green wrote in the opening of his well-used, often cited, highly acclaimed textbook of child and adolescent clinical psychopharmacology, psychopharmacotherapy should always be part of a comprehensive treatment plan developed after thorough clinical assessment, resulting in diagnosis, or at least a working diagnosis. And I think that's something that we always need to keep in mind. This is consistent with the American Academy of Child and Adolescent Psychiatry's practice parameters that are listed in the reference for this presentation. There is something that's a little bit different in what Wayne Hugo Green states here and what I'm actually recommending as an upshot of this presentation, and those that we share in other installments of TPICC. I think that psychopharmacotherapy could actually be implemented as an initial treatment plan, that is, initially, but it still needs to have a thorough clinical assessment to result in a diagnosis. And that's really what I'm saying here about psychopharmacotherapy being part of a treatment plan. It can be part of an initial treatment plan and as a requirement, and ultimately part of a comprehensive treatment plan. So let's meet our first objective. Our main objective is to list the 3 requirements and 5 guidelines regarding safe and effective psychotropic medication prescription for prescribing to youth with depression and anxiety. So here are the requirements. Before prescribing psychotropic medication to youth, we need the comprehensive assessment and at least an initial treatment plan. Working knowledge of state laws pertinent to prescribing psychotropic medication for youth, and we also need informed consent. And the latter, informed consent, will also be addressed in our guidelines. Well, what's meant by a comprehensive clinical assessment? We've been talking about how we need that clinical assessment to inform our treatment plan. Okay, in other words, we need to diagnose to determine the best treatment. We need to consider the presence of medical and psychiatric comorbidity. At the very least, a medical condition such as overweight and obesity, and a psychiatric comorbidity such as the presence of depression and anxiety together, or the presence of ADHD along with depression in that overweight youth. Because we know that psychiatric disorders commonly co-occur with depressive and anxiety disorders, or that is to say, the depressive and anxiety disorders commonly have psychiatric comorbidities such as ADHD, eating, and or substance use disorders. So part of what we're doing in performing our comprehensive clinical assessment is to establish an initial baseline, if you will, language that, Hernan, I'm sure you're very familiar with hearing what, or establishing what baseline is clinically. We want to establish our baseline of signs and symptoms, because we're going to want to identify clinically useful signs and symptoms later as our target symptoms that we'll monitor during treatment. It's also a requirement that we know the pertinent state laws. State statutes in New Mexico pertain to psychotropic medication prescription for youth. They require that informed consent be given. Makes sense. Anybody prescribed psychotropic medication really has a right to permit that, to give permission, if you will, as consent, and that be necessary before psychotropic medication be prescribed to them. And they need to be informed as to what they're consenting to. And this really has a historic basis in the statutes of our state and other states, having to do with the least drastic means for permitting treatment and yet ensuring the safety of the individual. Well, we know that those who are 18 years and older are of the majority, and they can give their own informed consent. Those who are under 14 need their legal guardian, legal or custodial parent, or either parent to consent for them. It's when youth are 14 to 17 that we have this rather gray area, if you will, whereby 14 to 17-year-old adolescents can give their own consent for psychotropic medication prescription, provided that their legal guardian is notified. That being the letter of the law, we also can consider this further in our guidelines. The informed consent process is so important, and it essentially is a process more than merely a directive. It involves more than signing a consent form. It needs to be performed by the primary or the prescribing medical provider. And it's comprised of presentation and discussion of the following elements as applicable before consent is given and the medication is prescribed. Those that I've highlighted as the initials IABR for the indications, alternatives, potential benefits versus risks or untoward effects. And there are some catchier ways of rearranging those letters to make a better acronym. But clinically, it makes more sense to me to start out with the indications. Why this medication is being recommended. Why we're having this discussion. For example, you're clearly having signs and symptoms of depression, or this could be a conversation with a parent. Your son is clearly having signs and symptoms of depression, including vegetative signs. These indicate a trial of antidepressant medications since they are not remitting with psychotherapy alone. Alternatives. There are other agents that have been used, such as herbal remedies, some nutritional supplements, such as forms of folate, discussed in Envision, telehealth, elsewhere. St. John's wort is a herbal remedy that's been used. Other supplements, such as other serotonergic compounds like tryptophan, are alternatives. Another alternative is to not take any of these agents and continue to do other things to enhance or alleviate depression, such as exercise and dietary improvement, lifestyle changes. We want to talk about what the potential benefits are, which would mostly fall under alleviation of the signs and symptoms for depression. And compare and contrast those works well for me with the risk or untoward effects of the medication. We need to be sure that, especially when prescribing for youth, that we make the distinction between FDA-approved and off-label prescribing whenever off-label prescribing is being considered and information is imparted about. The clinical approach and how we do this can really enhance safety and efficacy. Well, informed consent answers another point that Manan brings up in Head Case. According to what he wrote on page 68, the doctor hears your story and prescribes an antidepressant. Do you take it? This is a state of ambivalence or doubt, if you will, that really should not be in the mind of the individual who the medication is prescribed for after they leave the clinical encounter. I mean, beyond how we all have some ambivalence about most anything, so said Sigmund Freud, before psychotropic medication is prescribed, the informed consent process literally should provide sufficient information to answer any question or concern that the patient and their guardian or caregiver has about the medication. So looking at our sequence, the indications would be depression and anxiety, signs and symptoms thereof. Alternatives I just described versus and the potential benefits versus risks or untoward effects. And that last category is so important because it's on the minds of everybody who's being recommended a medication. Most everybody. So often, one of the first questions we'll hear is, well, what are the side effects? What happens if I get side effects? Won't that medication harm me? Well, if we can talk about the whole issue in a broad perspective to begin with, talking about side effects in general versus those that are specific to antidepressants. Those that are common must be covered, and those that are rare and yet serious. In the general approach, it can be helpful to talk about, and Hernan, I gather you are very familiar with this, how the list of potential and documented adverse effects or those associated with a medication can be as long as our arms for aspirin, Tylenol, ibuprofen, let alone psychotropic medication. So we really need to think about, yes.
It's so true. The problem is that we've sort of become desensitized to doing what you are suggesting be done, which I think makes absolute logical sense, because we use so many medications that have this enormous list of side effects, and we really never even mention it to parents, such as aspirin, or such as Tylenol or ibuprofen, to put an example. So I think it's very true, but from a prescriber's point of view, I have to admit that I am a little bit desensitized to doing this, although I think it's essential to do it with drugs such as the antidepressants. And so
I agree. And it's very easy to become complacent about the side effect information and the whole issue about side effects. And I think we can address some of the reasons for that when we talk about how ordinarily there really are more benefits than side effects to medications. That fits with general, okay? And that's true of antidepressants alone, which is the more specific part. And I think if we are doing the most justice to and for our patients, we're going to want to say to them, taking this ibuprofen without food could really upset your stomach. And taking large doses of this medication can cause further gastrointestinal symptoms, including bleeding. And you can prevent these by being sure that you're eating food with every dose of ibuprofen. Rare, although serious, side effects of ibuprofen can include kidney damage. And I think if we cover the most common ones on the one hand and the rare but most serious on the other, then the ones that are in between, I think we have to be less concerned about. Hernan, what's your impression of that?
Well, I was just thinking in practical terms. When I'm seeing between 4 and 6 patients an hour,
yes,
of which 6 patients are probably going to be receiving an antipyretic, the amount of time required to do that explanation on every single patient, it becomes a little bit impractical. And I'm just referring now, I think this is an issue that doesn't have that much to do with antidepressants, but it has to do with the fact that there are 2 forces in play. One is the fact that if you don't inform the patient, you might get sued, which gets people to over-expand their explanations. And secondly, this desensitization in which, since every medicine has a side effect, and we know it happens very, very rarely, we just omit mentioning it to the patients, or simply assume that the patient should know because it's a matter of
Hernan, are you still out there?
Hi, Hernan.
hello.
We got
I'm
you
glad
back.
you're back. Hernan, can you hear us?
Yeah, I can hear you. I gave you a long speech, and I was talking to myself apparently.
we heard you describe about how hard this is when having 4 to 6 patients to see in an hour, and how and including at least one of those will receive a prescription or recommendation for an antipyretic.
Right, yeah. But, the truth is I was commenting on that. I think what you are describing right now is essentially what needs to be done, and I don't want to imply that it shouldn't be done. I was just mentioning it as a factor in which in the general population of physicians that are practicing general pediatrics might be a little bit less careful about going into a very detailed explanation of all these alternative benefits. But it's very important that we learn to do it when we are dealing with these kinds of medicines. But I don't know.
Yeah, I think that this would be seem like a pretty meticulous approach for most busy primary care pediatric providers.
But it doesn't make it any less important. I think anyone prescribing these medicines, don't get me wrong, I think should go through this process with their patients. I think the patients...
We really need to, and I think we find ways of speeding it up while being sure to cover rare yet serious exacerbations need to be mentioned, such as suicidal thinking and other harmful behaviors. One way to address that is to say the jury's not out on that yet, or the jury is still out on that. It seems to be due to more than the molecules in the medication alone. Most importantly, we need to meet more frequently so that there's adequate clinical monitoring while initiating this medication.
Good.
And I have a question.
Yes, Lauren.
If you have the child in the room with the parent and you're talking about the medications, do you change how you address the side effects, or do you still just, you need to let the parents know, so say what it is?
It depends on age and the development of the child. So for example, if this is a 10-year-old child, the conversation is really being had with the parent.
Right.
As the child is getting older, through 13 years old, definitely trying to include them into the conversation more for their assent. So what we can think of is through elementary school, or at least through about 4th grade, 10 years old, then it's really with the parent. From there on, with the youth and the parent, and thinking about the youth agreeing, that's assent, and the parent giving the permission, consent.
Okay.
Through 13. And then once they're 14, it's really a conversation with the youth, unless other developmental considerations such as a developmental disorder, mental retardation, insufficient capacity intellectual capacity and adaptive functioning for being able to make a decision for one's health and safety.
Okay.
Or also known as competency. Yeah. And then I mentioned the FDA approval being needed. Since only 2 of the antidepressant medications are approved by the FDA for the treatment of pediatric depression. Hernan, you are likely comfortable with the discussion of off-label prescribing because it's not only done in child psychiatry, it's really done throughout pediatrics, that we've really needed to prescribe medications that have not yet received the approval of the FDA.
That is very true, and I think the list is a lot longer than I think what we give it credit for. It's so long that, again, it's something that I have to admit, for instance, I don't usually mention unless it is something very special. I don't particularly mention that, these medications have not been approved for the use on children, or that there is not enough evidence to that fact. And I think an example would be, a few years back when we were using chemotherapy for influenza.
Oh.
We had no studies for the younger generation, and yet sometimes we did use it.
Are you talking about Tamiflu, for example?
Exactly. Okay. That has become approved, for younger ages only recently, and
yes.
even with some qualifications.
And likewise, even with adults, I think that there has been some support for trying amantadine with adults when they first get the flu. But I don't think that the FDA has approved the use of amantadine for that indication.
Yeah, I think amantadine has been demonstrated to be, the influenza viruses in existence right now are all resistant. So during the flu season, the recommendation from the CDC is not to use amantadine at all.
Well, and you see that that's an important point. The CDC makes the recommendation because they know the standard of care. And I think one way to briefly address this issue is to explain to youth and their guardians that while this medication has not received FDA approval, it has become part of the standard of care for your child's condition or for your condition.
Uh-huh.
I end up bringing it up about these medicines because so often people go home to surf the web and they look up information about the medications, and if they see glaring things that have not been part of the conversation, they lose trust in what we do and they're more likely not to try it.
Yeah, and I think that's very, very, very wise. I don't want for you to get the wrong impression, though, because I think that what you're suggesting is exactly what I think anyone who prescribes any of these medications should absolutely do before prescribing the medication.
Yeah, thanks for that endorsement. Certainly appreciate it. And hence it's part of today's discussion. I also wanted to comment more about the process of informed consent. It's the discussion that's required. The taking of the medication is optional. That is the matter of consent that the patient or guardian gives. It includes a description of the clinical rationale, and ultimately, by the time we have that discussion and consent is given, sufficient information has been imparted such that those involved feel that they are knowledgeable enough to make the best choice in this matter. And that might be that they decline. They feel that they've gotten sufficient information. They don't like that there's a possibility of a manic or hypomanic exacerbation of somebody, a teenager with who's found to be at risk for the development of bipolar disorder due to their family history. And they don't like it that the medication has had any association with suicidal ideation and other harmfulness. Well, whereas our lists of requirements are certainly necessary, our guidelines are suggestions for effective clinical acumen. We need to balance risk with the clinical need and indications, monitor frequently, identify and communicate the target symptoms alluded to earlier, and as also mentioned previously, approach informed consent as a therapeutic psychoeducational opportunity for youth and others involved. And lastly, develop a comprehensive treatment plan. Balancing and monitoring are so important because we always need to balance the risk with the clinical needs and indications during decision making and informed consent. We need to have ongoing, periodic clinical monitoring while prescribing psychotropic medications. And this monitoring can be through our clinical observation, reports from family, parent, the youth, their teachers. We need to have regular follow-up visits and reassess at intervals sufficient for determining changes in target symptoms and development of untoward effects. Well, target symptoms can be syndromal. They can be specific symptoms, signs, behaviors, okay? And it's important to communicate what the target symptoms are. Now, a target syndrome would be combined features of depression and anxiety disorders, okay? Whereas the symptoms or signs would be individual features of those. And by communicating what they are, others, such as parents and guardians, will know what to watch for. Excuse me. Whereas sometimes we choose that we don't want to communicate that information to some individuals who we don't want to share the fact that the youth is taking medication. Now there's some things that we definitely don't want to do, so I included these 7 deadly sins of prescribing that were presented a few years back by Elizabeth Reeve was actually a medical student, colleague of mine. So as we are in alphabetical order in medical school, we were at adjacent cadaver tables, which was, of course, gross anatomy, and nearby microscopes in microscopic anatomy. Elizabeth states very well, it's really a disservice to our patients when we fail to prescribe and treat. We may have fears about doing that, anxiety about doing that, but if somebody has a severe depression, they can be at risk for suicide, other harmfulness, accidents, etc. So to not treat them is a failure. It's also a failure to not set specific target symptoms. If we don't do that, then we're kind of golfing in the fog. We're not really monitoring like we could. Failure to monitor at all is unfortunately a downside. We need to frequently monitor. Too often medications are started and then they're not adjusted. That often can be less helpful. Okay? Medications can be started and adjusted too often, and this often is the case in psychiatric hospitals where the length of stay is short and the pressures to make changes and show that to third-party payers are rather intense pressures that can sway us in our prescribing and adjusting patterns. We want to be careful that we don't set wrong expectations, such as, take this and your depression will all go away. We also want to be sure that we're not continuing medications that have no demonstrable efficacy. And I'd have to say that as a psychiatrist who will meet youth for the first time who are often taking medications, sometimes it's not clear if the medication is actually helping them. It also turns out hand in hand with that is that I can't get as good of a clinical assessment of what's going on with somebody when they're on medication. So it becomes an opportunity to recommend tapering down on medication. Reminding me of a challenge with one of my clinical cases right now, and to get the buy-in for doing so in order to enhance the initial assessment and the adjustment of the medication. Now, as we approach informed consent, it's really important that, and is a reason for taking some more time from the standpoint of behavioral health for a therapeutic, psychoeducational opportunity for youth and others involved. It is part of a comprehensive treatment plan where the psychoeducation comes under that rubric of psychotherapy, where we have psychopharmacotherapy, where we want to make sure there's some health care maintenance. Are there continuing to be, for example, an annual physical exam? Are other health and medical problems being addressed? How is the activity of this individual, and could it be increased to enhance their treatment? How is their nutrition? And to recruit case management whenever available, if needed. Multimodal treatment is usually an important part of a comprehensive treatment plan because psychotherapy and psychopharmacotherapy, for example, are very important aspects of a multimodal treatment plan. It's the combination of these therapies that enhance efficacy. They're consistent with the biopsychosocial model and etiology for depression, anxiety, and the comorbidities that need to be addressed. Integrated care, where we're bringing together behavioral health and medical to work together to prescribe medication, monitor its effects, and provide psychotherapy, is efficacious. And the combination of those two main modes of medication, psychopharmacotherapy and psychotherapy, is usually superior to either one of those alone for the treatment of depression, anxiety, and other conditions. Nevertheless, the American Academy of Child and Adolescent Psychiatry recommends starting the treatment of depression and anxiety with psychotherapy alone, especially with younger children. Meanwhile, the combination of psychotherapy and medication is increasingly considered first-line effective treatment for adolescent depression and anxiety, especially when it is severe. The American Academy of Child and Adolescent Psychiatry's policy statement on prescribing psychotropic medications for youth makes the point that whenever psychotropic medications are prescribed, there needs to be psychosocial interventions, including psychotherapy, in the treatment plan. The Child Psychiatry Academy definitely is not endorsing medication-only treatment for depression and anxiety. Now, there is some evidence basis for the combination of the two, the therapy and the medication. that did show that when fluoxetine or Prozac was prescribed along with participation in cognitive behavioral therapy, there was greater efficacy for either mode alone. Okay? Now, the further explanation of this is that it needs to have the following phrase added on to the end. For the acute and other early phases of treatment. But with longer term and maintenance treatment, it doesn't show as much advantage. So you'll hear mixed responses. Oh, it showed that psychotherapy plus medication was as good as psychotherapy alone. Well, for adolescents who had been in treatment for periods of like a year and a half, that was shown. But for individuals who were in treatment for the first 3 to 4 months, the combination was superior. And since that is the time when youth are at greatest risk for suicidality, it's really important to combine the treatment. So you see here in the notes, especially during the acute 3-month phase and continuation phase, another 4.5 months. And that there is similar efficacy approached by 9 months, and then by later they're even quite similar. So that is the end of this part 1 on requirements and guidelines for prescribing psychotropic medication to youth for their depression and anxiety. And I would like to open up for questions.
Yeah, you know, I think this presentation you have is just fabulous. I wish my colleagues, every colleague should have, because it doesn't deal, it's not just wise from the point of view of psychiatry, it's also very wise from the point of view of general medicine. And it's a very, very easy to follow presentation, which is, I found it very, very stimulating. One question that I have, do you ever include in your discussion, in your initial discussion, the potential for inappropriate use of these medications?
Depending on the medication, I sure do, Ernan. So, for example, bupropion, known as Wellbutrin, is one of the antidepressants covered in the next section on medication selection. That medication should not be prescribed for, well, first of all, I'll bring up contraindications. Individuals who have seizures, and at the same time, I'm wanting to make sure that the patient I'm about to prescribe it to doesn't have seizures. But I will also include in the informed consent about that those individuals who had seizures had metabolic problems due to eating disorder that set them up for seizures, at least in part. So it will end up being an opportunity to say, this medication is not to be taken by somebody who is having a metabolic aberration, an eating disorder, or seizures. Plus, taking the medication inappropriately, such as taking very high doses of it at once, can cause an individual to have seizures.
What about the possibility of abuse? Say if you're using an anxiolytic or something like that.
Indeed, and if I was promoting the prescription of an anxiolytic, that would definitely be part of the discussion. What you'll see in the next section, hopefully in our next installment, that what's recommended for the primary medication treatment for anxiety disorder are SSRI antidepressants, and in some cases SNRIs. And reserving the use of anxiolytics for acute anxiety for a very limited term.
How about medications for sleeping?
Well, that falls into similarly with the anxiolytics, since they would be hypnotics. Certainly they can be harmful, okay? They can cause somebody to have altered level of consciousness or become very sedated. I would also include, if we're going to consider an older antidepressant in the TCA class, the tricyclic antidepressants, those can be very dangerous when over-ingested. They can cause death. So we don't want to allow those medicines to be abused by somebody, similarly with the MAOI antidepressants. And of course, psychostimulant medication is one that is at greater risk for abuse potential.
So, can you briefly, or maybe you could in the next session, I don't know, how do you approach that? Because it almost implies a certain accusation to the possibility that they might abuse it when you are talking to the teenager.
Well, for one thing, I would talk about the potential for untoward effects by taking too much of it, such as mentioning tics, mentioning other muscle stiffness and even abnormal movements. I would try to incorporate that into, again, the informed consent process. These medicines have been associated with the development of tics. Taking more of this medicine can be really problematic because of development of tics and other unusual movements. Plus the fact that taking too much of the medicine could increase heart rate substantially, blood pressure, cause arrhythmias.
I have to comment too on just to second the notion that this PowerPoint was really generalizable, because from a nutrition standpoint, when you were talking about, people go back to TV and they see ads about Zoloft and everything, and they wonder why they weren't prescribed that. From nutrition, we get asked all the time about fad diets, about nutrition supplements. Dr. Oz said this, like that has to be right? And it's hard because you lose that credibility with them so fast because they do have this false advertisement from media and everything. So that was really interesting to hear it's not just our field.
Indeed, and actually I start to cringe a little bit when I hear that patients, well, especially their parents and other caregivers, say, oh, we don't have to talk about that. I'll just go look it up on the internet.
Yeah.
That is an orange flag for me, that we could have difficulties getting this part of the treatment plan underway, or at least having the discussion, because that internet viewing will tend to take place of the needed discussion in a distorted way.
Yep, oh, definitely. Or even WebMD, I mean, it's a great idea, but then people plug in their symptoms and it spits out like the worst thing possible.
Oh, yes.
It's hard to combat that. And
yes, it is, especially when you can get an answer so quickly.
Right, yes, definitely.
Well, I think we're coming to the end of our session for today. Hernan, Warren, Kevin, thank you very much. And again, my apologies for starting a few minutes late there today.
Thank you.
Well, Dan, thank you so much. You know, this let me tell you, this is a beautiful presentation that I think goes, again, I'm repeating myself, but it's something that any person who prescribes any medications should look into, because it applies very well to what we should be thinking about as we are prescribing. And thank you so much for giving this.
Hernan, before you sign off, I sure would appreciate your input as to what's chosen to be covered next time. Would you like to see us move on to the discussion of medications, that is the psychopharmacology? That
Absolutely,
I call selections?
Yes. Yeah,
Okay.
I think that's terrific, yes.
We'll do that then. Great. Thank you, Hernan.
Well, thank you, Dan, again.
Take care. Bye.